What are women offered after a caesarean birth pain relief wise to help aid their recovery and also reduce any pain or discomfort? And does it feel really barbaric? Now in this video, I'm going to discuss two main parts. Firstly, what are you normally prescribed? Now this can be very individual, but I'll go through the normal things that are prescribed to women. And the second thing is administration of those medications and the challenges that poses within the NHS setting. So firstly, what are you prescribed after a caesarean birth? So as standard, you are prescribed paracetamol, and if you are not asthmatic, you're able to take non-steroidal anti-inflammatories, you've not had a huge postpartum hemorrhage, or alternatively you're not preeclamptic, you haven't got ulcerative colitis or Crohn's for example, then normally what is prescribed is diclofenac after birth in most trusts. That's a suppository up the bottom that gives you up to 18 hours worth of pain relief, and then it goes over to ibuprofen, normally around 4 times a day, depending on your own medical history and also what is normally prescribed within your trust. This is a slightly higher dose that is normally prescribed compared to off the back of the packet for ibuprofen. And some trusts will recommend that you bring in ibuprofen and paracetamol so that you could administer them yourselves, which comes down to the administration part that I will cover a bit later. Now the next part, I would always recommend having a conversation with your community midwife, your obstetrician when you are planning a caesarean birth for example, or the midwife is providing care for you in that post-operative, postnatal recovery period. Every trust is entirely different and they really base it not only on what they would regularly and routinely prescribe for the next parts, but also your own individual medical history. There are some people who can't take certain medications because of medical conditions, because of pregnancy conditions, for example, because of previous obstetric complications that they may have had. They also may have allergies as well. But many trusts will also offer something called dihydrocodone, which is an opiate medication that you can take orally. This medication is actually absorbed far better in your gut with paracetamol, so taking it at the same time as paracetamol actually aids the absorption, which means you get better pain relief from taking it together at the same time. The downsides of dihydrocodone though is that it is an opioid medication and it can increase the chance of constipation postnatally. And I always recommend that if you have an opiate medication, something like dihydrocodone for example, or potentially Oromorph, is that you should be also taking a laxative to help soften the stools to move things through. And women can go home with all three. So paracetamol, ibuprofen, women are normally expected to get that because it's far cheaper to buy off the shelf and have at home yourself. But dihydrocodone is normally prescribed for you to be able to take home if your trust offer this and prescribe this for women post-operatively after a caesarean birth. There are other medications that can be prescribed to help with your pain in that postnatal period as well though. And one of those medications is oral morphine. And most trusts do this on a PRN basis, so as required. So when you call your bell, you tell them that you're in pain, your midwives can go and get you the oral morphine for you to take. It's about every 1 to 2 hours on average. And sometimes if you're unable to tolerate any oral solution, they can provide you an intramuscular solution of the morphine, or alternatively intravenously as well, if this is prescribed on your drug chart and it's been a discussion ahead of time. Or alternatively, if you are requiring intramuscular or intravenous morphine and nothing else is working, particularly if you're sort of a day or two down the line, then what we also need to be considering is there anything else going on causing this severity and increase in your pain postnatally? There are several reasons why morphine is something that you have to request as opposed to something that's being given to you regularly. Firstly, you have a spinal anaesthetic. This gives you pain relief for up to 12 hours after the birth in most cases. After a general anaesthetic, more often than not, a PCA, so patient-controlled analgesia that goes into the veins of morphine, is given in that immediate postnatal period to help with the recovery side of things. In some places after a general anaesthetic caesarean, they also inject local anaesthetic around the wound as well to help with that post-operative pain relief. This again is dependent on your individual trust though. But going back to the oral morphine, it can increase the chance of constipation. Constipation, especially after a caesarean birth, can increase the chance of a risk called paralytic ileus. This is where the bowel doesn't work as it should do. It can cause severe pain, it can cause readmission, and in those really severe cases, it can mean a readmission with an NG tube being put down. This is a really rare complication though of a caesarean birth. The actual statistics are anywhere between 10 and 30% of all caesarean births have some degree of paralytic ileus. For the really severe end of the spectrum with paralytic ileus, they estimate only around about 0.6 to 1% of all caesarean births will need readmission and NG tubes and much more treatment than that. It's also why I'm a huge fan of chewing gum in that postnatal period. The moment you hit recovery, pop some chewing gum, try and get that bowel motion moving around. But it's also why I'm a huge fan of mobility as well. Around that 6 to 12 hour mark where you can actually get out of bed and start moving around, please do. The reason being, the more you move, the more your bowels will start functioning and moving around as well, and that can really help with preventing that complication. Now, the other factor why there's not huge amounts of medications that are given in that postnatal period is firstly because of your conscious levels. You don't want to be really drowsy with a newborn baby. You still have a baby to care for, and I know that seems absolutely barbaric, is that you've been through major surgery and now you've got a baby to care for. But you do need to be awake enough to be able to look after your baby. The more drowsy a mum is, the more likely they are to drop their baby, not be able to provide care for their baby. And if they are at home at that stage, also for things like accidental co-sleeping too. There is one other medication that is sometimes used as pain relief post-operatively after a caesarean birth, and that is tramadol. They are, in the rare cases, can I just point out, on a really individualised basis. Tramadol can cause real doolally feelings and thoughts for some women. It doesn't agree with them. Again, it can cause constipation because it's another opioid, but sometimes it's prescribed for women who can't maybe have non-steroidal anti-inflammatories, who are really uncomfortable and in pain, maybe women who can't have paracetamol, for example. There's a whole array of reasons why tramadol might be prescribed, but again, it can cause real drowsiness, actually make people feel really out of it as well. And the other thing to consider after caesarean birth is that many women choose to and want to breastfeed, and all of the things I've discussed can be used with breastfeeding, all of the medications, and that's why it's fairly standard and routine after caesarean birth for any of those combination of things to be offered. And I love the Breastfeeding Network. Highly recommend that if you're planning on breastfeeding that you go along and check them out. You've got all the side effects on dihydrocodeine, oral morphine, tramadol, for example, paracetamol, ibuprofen, diclofenac, non-steroidal anti-inflammatories. They're all in this fact sheet so that you can see what the impact is on babies but also milk. So there is more than just paracetamol and ibuprofen offered. It does depend on your trust. It also depends on your own individual medical history. All women should have a review either prior to an elective caesarean birth where you can discuss your pain relief options and get them prescribed ahead of time. Or alternatively, if you've had an unplanned caesarean birth, you should have a review on day one after your caesarean birth, or maybe later on that day before going over to the ward, where all those medications can be prescribed. Always ask your midwives if you need anything more than the paracetamol and ibuprofen, if nothing else is prescribed. And if not, ask them, what is on my drug chart? What can I have? What options have I got available to me? And what are the side effects and risks of those? Now, if you've made it this far, I just want to touch on some of the challenges with the administration side of things. We know from the CQC reports that women aren't receiving the medications that they should do in a timely fashion on wards. And I am really sorry if you are one of those women who has been impacted by the delay in medications being given in that postnatal, post-operative recovery period. And if you have been one of those people who have been impacted by the lack of pain relief postnatally, not being given it when you've asked or requested for it, I just want to say a massive sorry and apology. We know that things aren't good enough at this moment in time in a lot of women's health services, but in particular maternity services. And there are lots of reasons for this. Firstly, staffing. There are no minimum safe staffing levels on maternity wards. They only exist in a one-to-one care setting in a labour ward intrapartum experience. The moment you go into labour, that's when you should have one-to-one care. And there's huge variation. One midwife could be looking after 12 women and 12 babies, or 6 women and 6 babies. Babies are not counted in the safe staffing levels because you, as a woman, are expected to look after your baby. And yes, I absolutely hate that. That's a story for another day. But if you are looking after lots of other women and something happens to one of your other women, that delays other people getting their medications. Next is communication. So lots of women don't know that they can have oral morphine as long as they actually request it and they call their bell for it. And that's something that needs to happen again, conversationally, antenatally, or after birth. And the final thing is finding another midwife to check oral morphine out. It's a controlled drug. It requires 2 midwives in most trusts to be able to get out. If you're on a busy ward of 30 women with only 3 midwives and those other 2 midwives are in other rooms, you've got to wait for them to come out and be available before getting it, which causes delays.